Stand by everyone. Thank you, Danish and Dr. Shahid and Apna, everyone to give me the opportunity to come over here and present. And the topic has already been nicely presented by Professor Ashfaq, Ismail, Dr. Ismail, and Dr. Shahid. So I'm going to skip the IVTPA and just show you a few slides of Neuro-Endovascular, and then maybe concentrate more on the issues with the future direction of the stroke care in Pakistan. So that probably I'd like to focus more. So broadly speaking, who are the patients who can be considered for Neuro-Endovascular? One is obviously who is not a TPA candidate, meaning that anyone who comes beyond 4.5 hours or is a wake-up stroke because you don't know the last known well time, so obviously it's not 4.5 hours. Or they failed TPA, or you already know from the examination that it's a large vessel occlusion and the TPA is not going to work. So that, those are the patients who are going to definitely benefit from endovascular. Obviously, just in the previous presentation, you've heard that the collaterals, they definitely help us a lot for patient selection. If we know the collaterals are there, it's a good chance that the patient will benefit. Now, practicing in an underdeveloped country, like a developing country like Pakistan, it's not easy to practice these things in Pakistan because of the financial constraints. Because if you don't produce the results, at the end of the day, the family is going to be asking, "Kitna bill ban gaya? So what do we do?" or something. And that's a daily problem that I have to come across. So moving forward, it has more efficacy, effectiveness with IVTP as compared to all the endovascular procedures that we do. And so the guidelines already state that they should be considered. There are different techniques that we adopt. One is that the clot is there, you can go in and infuse intra-arterial thrombolysis, you can do TPA, and now the tenecteplase is out, so hopefully more and more cases of those will be tried. You can do a stent retriever, you can partially engage the clot, let the flow establish and gently pull the whole system out, or you can go in and aspirate the clot out. So these are the three or four big things that we can do. The other simple ones are viral manipulations or microcatheter manipulations in areas where we have difficulty reaching or there is a lot of vascular tortuosity. And in Pakistan, because of uncontrolled hypertension and diabetes, that is a very frequent thing that when we go in, the vascular is so tortuous that we have to struggle a lot trying to get to the vessel of occlusion. So I'm not going to go through these studies, and these are the 5 big ones, and one of them, Escape, Professor Ashfaq already pointed out, they were part of the study. It's their center which actually came up with the results, and it was positive for endovascular. So I'm not going to go into the results. The nutshell is that endovascular treatment has better efficacy as compared to IVTPA. So recently this paper was published in New England Journal where they compared IVTPA with mechanical thrombectomy versus IV tenecteplase with mechanical thrombectomy. So the group which actually was, sorry, I pushed it. The group that received tenecteplase and thrombectomy had a better efficacy recanalization as compared to TPA and thrombectomy. So quickly moving through the guidelines, I'm not going to bore you, but there are certain guidelines which actually specifically talk about the time windows. When we are talking about 6 to 16 hours, we are relying more and more on the neuroimaging. Unfortunately, in Pakistan, we don't have that luxury of CT perfusion or MR perfusion in Lahore. The first one that I know of is recently Shahid Khanum installed it, but again, it's a cancer hospital, so it's not going to be easy to go send patients there. And I think some of the government hospitals also have the software, but it's not being used. And CT perfusion, definitely, I've not seen anyone doing it over here. So going back in time, this is the first trial in 1998 that actually came out where they looked at intra-arterial thrombolysis. And so it's my 6th year now back in Lahore, Pakistan from US. So, and what I've learned is that you have to adopt, you have to change. You have to adapt to the local circumstances and the geographic domains. So maybe the thrombectomy is much better in the Western world, but here it has a very high cost to it. So a stent retriever, just one stent retriever is around 225,000 rupees. It's not like what the CJ has been going around saying that all the stents have to be 1 lakh se kam ke ho sara kuch. It's not the case here. So it's just one retriever can cost this much, and then you have to throw in a lot of other disposables just to get the retriever up. So आसानी से 4-5 लाख का बिल बन जाता है, even if you exclude the hospital cost and the operator cost. So So that is a big issue. So here, like I've used cases, thought of like cases where I can just use intra-arterial thrombolysis. So intra-arterial thrombolysis, I have to think twice before I open a TPA, because TPA vial 50 milligram is around 67,500. If I use 10 milligrams of TPA, so I'm going to add the price of 67,000 to the patient procedure. But I've used Aggrastat 2 milligrams, 3, 4 milligrams, which is a GB2B inhibitor, and dilute it and go in at the clot and then just infuse it over 10 to 20 minutes. So, and I've had no major problems. But this is a case, a 55-year-old last known well 5 hours ago, transferred from the hospital around 8:30 in the morning. Very high stroke score of 20 to 23, which is falls by the NIH stroke score, like severe strokes. We went in, we looked at the left vertebral artery, we found that the basilar is occluded. There's a lot of tortuosity in the vertebral artery. We couldn't see clearly the right vertebral artery, but it's present. But there was something growing here, and the patient had a bovine arch. We just could not access the right vertebral artery, but from the left we found that the basilar was occluded. And his clinical exam also pointed out that his problem was posterior circulation. And 2-3 weeks ago he came in walking again, and his score is like around 6. So this is something that really works. But again, the patient selection is very important. So this is another case, a 71-year-old hypertensive hyperlipidemia, an interesting case because it really exhausted a lot of human resource and manpower and trying to get this patient from one facility to another, trying to manage the ER, trying to manage the blood pressure, not having IV antihypertensive drugs in majority of the hospitals readily available. So these stroke cases are not easy to manage here. And 6:30 to 8 becomes mute, and then but is receptive. 8:20 starts complaining of heaviness, right-sided symptoms start coming in, starts crying because he's having difficulty speaking. Blood pressure at that time is 155/95, not bad. Is taken to the hospital nearby by his son. CT brain saw like a dent sign there, and they referred him to our hospital at around 11:30. So starting somewhere around 6:30 to 8 and 11:30, 3 hours 10 minutes. Score is 4. We thought that he's a good candidate for IVTPA, and then once we started the IVTPA, his pressure started to shoot up, and then he had a seizure on the table. So we kept on trying to manage everything, and then after 15-20 minutes of infusion, we stopped, and we had already were preparing to take him to the cath lab just in anticipation if he doesn't improve. So we rushed him upstairs, and at that time, before he went in, his score had gone from 4 to 13. So, and the TPA now is used and is charged to the patient, but we only used 15-20, but he could have received 90. But it's we saved the TPA because we thought we might use it in the angio, and luckily we did. So when we went in, we found that there was a thrombus, not like a readily occlusive one in the MCA branch, and you can see that the collaterals are now trying to come in, but there is a filling defect. And we infused approximately 10 milligrams of the same TPA that we had opened up, and then his vessels clearly opened and there was no perfusion deficit or anything. So we were able to recanalize it within 6.5 hours by just giving intra-arterial TPA. So this is what happened with him. His score initially 13, at day 2 4, and at 2 weeks 0. And his CT just showed a very small hyperdensity in the portal area, and that's about it. But he overall has done extremely well. So now, if you go back in time again, this is the first device that was approved called Mercy device. It's basically a corkscrew. You threw in the loops, you engage the clot, and you occlude the carotid, and then you gently take the system out while you're doing the negative aspiration through the carotid occlusion. And so these things look very nice on the videos. It seems that you go in, you take out every clot, but sometimes you don't because some of the clots are very wicked and very tough to take out. And this is how the animation looks like. So this is now, the Mercy is no longer used, at least like, I don't know if anyone's using it anymore, but this is one of the cases when I was there abroad in US. This was my first case that I did, And it so happened that we did it on a patient who was actually 13 hours into the symptoms. A 24-year-old woman with 9 hours history of acute dizziness went to one hospital, then was finally referred to us, was not a TPA candidate, and this is how the imaging looks like. We took her to the cath lab. She was awake 5 minutes talking to you, and suddenly she would go in coma. You would have to do sternal rub, wake her up, converse for a few minutes, and then we'll go back again. And when we took her to the cath lab and we found out why she was doing it, because there was a thrombus sitting in the basilar. And these are the thalamic perforators, which actually can put you in coma if they occlude because of the clot in the basilar. And this is just a magnified view. So here we did use the Mercy, and we went across it, and we did 2 passes, and the whole clot came out. And this is how it looks like. There was still a non-occlusive at the distal basilar, but overall everything looks fine. The perforators are in shape, but on this view you don't see the thrombus. And then when we did the MRI follow-ups, everything improved immediately after the clot was taken out. At 7 weeks, she was only left with cerebellar signs, ataxia. 3 months, she was walking fine, and you couldn't tell that she ever had a stroke. Now, in 2010, another device, the pulmonary aspiration system, came out. It's basically a vacuum pump. You go in, close the clot, you have a separator, you gently start poking the clot, you try to fragment it. At the same time, you have an aspiration device under the table, and it keeps on sucking the clot out. And you just take out the clot chunk piece by piece. So for the sake of time, I'm just going to move forward. And then in 2012, the first generation of the solitaire devices came out. These are basically 3/4 deployed stents. You don't deploy the stent completely. You go in across the clot. You then deploy the retriever device. You let the revascularize the flow for 5 minutes or so, and then you gently take the system out. You can have an option. Some operators occlude the carotid, some don't. The studies are still going on whether occlusion, proximal occlusion is better or it's not. But for the sake of, for a country like Pakistan, the less devices, the less costly the whole cost of the procedure, and that's how it works.
This is fluoro guided?
Ji?
You guided fluoroscopy?
Ji, this is being all done under angiography. Yes, sir. So this is a case from here, like a 50-year-old surgeon was about to get into the OR when he collapsed, and smoker, very heavy smoker. He had a right carotid stenosis, thrombus sitting there, had a mechanism of stroke like artery to artery. And Dr. Ismail was telling you about the classification, the stroke classification. In this case, it was artery to artery because of a carotid stenosis. Had an M1 occlusion, was not a TPA candidate by the time that he came to us. So we did both aspiration and thrombectomy, and then we were able to restore it. And this is how it looks like after the vessel has been recanalized. We did the aspiration at the carotid and then made our way in through the device. And we left this one to be dealt with afterwards because we are not sure at that time how the patient is going to wake up. Is he going to have complete stroke? Because if we try to revascularize by putting a stent in, we are going to commit the patient to dual antipyretic, and that can be a problem if we later find out that the patient had a full stroke and we didn't do any benefit while we were revascularizing. So the patient actually, being a surgeon, he decided not to do anything for this, and he's back to work. So, and both the surgeon who can do endarterectomy and myself have called him, but we then decided to just let him go because it's his choice whether he wants to deal with it or he doesn't. But he's seeking some spiritual treatment therapy also at this time. So lastly, this is what I've started to now see that coming to Pakistan, you really have to learn from your demographics, your socioeconomics, and the other services. And one of the things that we should do is learn from non-medical side. And this is one area that I really wanted to highlight. In 2016, I think, Red Bull car made the world record of changing the 4 tires, can anyone guess how much time did it take for the team to actually change the 4 tires when the car stops?
40 seconds. 40 seconds.
Too much.
Less than
5
2
seconds.
seconds.
Little less than 4.
Wow.
4 seconds.
So they have a lollipop man. So I actually came up with something that the neurologist has to be the team leader, whether it's a lady or a man. So a lollipop man or a woman, and you have all these people who are actually working on that patient, on just one patient, and it's a teamwork. The problem in the developed world and in our part of the world is that they are far ahead and they've actually realized the importance of the teamwork. They've realized the importance of the time. Dr. Ashfaq like told you that they actually give TPA in the CT scanner immediately after the CT scanner. I can't even think of doing that even in Pakistan. Because those are different issues. But like the thing is that so they keep on thinking and they keep on changing how to save crucial minutes. And this is how we really have to work together and try to.
Don't too many cooks spoil the broth?
No, if
They
they are
don't.
coordinated.
If
If
you
they are
have
not
just-
coordinated,
Yeah.
yes.
So if you have one cook, or one main cook overseeing everything, then it should be fine.
So you don't need a cook, you need a chef.
You need a chef. Yeah.
You need a chef to direct everyone and it's done.
Exactly.
Or think of it as an orchestra.
Yeah.
So I'm just going to move to the main talk. So.
Do you have to worry about reperfusion injury?
Right, and that's, yeah. So the question is, do you have to worry about reperfusion injury? And yes, that is why it's very important to see how much is the actual stroke size, infarct, and how much is the penumbra, which is that risk area. If the stroke is already big, the infarct size is big, then you will have to worry about reperfusion.
Before I get myself into the direction of the stroke care in Pakistan, I think we need to learn from the basic facts. What are the facts pertaining to our country? What are the facts globally? So we fall in the middle income country, and by numerous studies, like at least 2/3 of the strokes globally do take place in low to middle income countries. So the other thing is that now since we have talked about TPA and we've talked about the importance of the time window, it doesn't mean that if the time window is up to 4.5 hours, so the patient is recognized at 1 and the family says, okay, someone is going to come and take you or take him or her, and the patient shows up at 2 hours. So studies have shown that the TPA given within 90 minutes, more than 3 months favorable outcomes are far higher as compared to someone who's getting between 90 to 180 minutes. So time is of essence. For every 15 minutes delay in treatment, approximately 4% reduction in probability of good functional outcomes. Every minute delay in treatment leads to at least 2 days of extra health life loss. And these are important. This is a very important fact because in our part of the world, we still do not value the person's loss from the community, from the work, and we do not take those things into account for when we're making our health policies. So like I said, in the developed world, the outcomes are getting better and better. They actually have improved their morbidity and mortality. Unfortunately, in the low-income countries, the middle-income countries, the graph is going up and up. Dr. Khatri, I think, pointed out that in this part of the world, our strokes are taking place 15 years earlier than in the developed world. And mainly because we have a different set of comorbidities like diabetes, hypertension, obesity is far more prevalent, I think, here as compared to the Western countries. So another basic issue is that we all quote numbers of how much is the stroke incidence and prevalence in the Western world. America, everyone quotes 750 to 800,000, but we still don't know how much is the stroke incidence or prevalence in Pakistan because we have not been able to do these dedicated type of studies, and from the research perspective also we are far behind. So the only thing is that there was one paper published in 2010 218 per 100,000 cases. So if you take this number, this study as the closest one that you can find, and if you try to now compare your numbers with USA, looking at the population of USA, I calculated that, you know, maybe that year we had this many strokes in the country by the previous number. Very close to, not far behind from US. Now obviously, I don't have anything to show you over here, but in the US, it's like around 800,000 up to 218. That's what their studies will point out. So if we are going to make any policies, if we're going to deal with stroke or any other health epidemic for that nature, we really need to know how much is the incidence and the prevalence. And that's where probably the community medicine comes in, right? So the other thing is that the guidelines that we follow and we've all talked about, do they really matter in this part of the world? Because we are dealing with a host of different problems. So the guidelines do help us, but I don't know if we can replicate them here. It's very difficult to replicate the guidelines here. Give you another example why it's different, because all the guidelines that we talked about in stroke are based on the CT scans. Without a CT scan on an X-ray, you cannot make a decision. You have to have a CT scan. So in 2010, around 70 million scans were performed in USA. I don't know how many are performed in Pakistan. Does anyone in this room know? So the only thing I know is, I got this number from Siemens Pakistan like a week ago. We have a total of 206 CT scanners in the whole country, compared to 6,000 in USA. And look at our population and see the access of CT scans. And these CT scans, majority of them by their description are old machines, refurbished ones. Because of the cost issues, that's the trend. The public hospitals will import new. All the private setups will probably be importing old machines. You wouldn't have the luxury of CT angios or CT perfusion on these machines. So again, the guidelines are coming from the Western world, but how do we counter this issue here? 34% of our strokes are mostly hemorrhagic type in this part of the world, as compared to the 9% in the Western countries. And in here, 84% will die because of the stroke, as compared to 16 in Hyman over the next 3 years of diagnosis. So huge discrepancies. Then we have racial differences, probably to account for what I just told you. Because in one paper from Japan, they looked at maybe the racial differences, genetic makeup was leading to more thrombolytic problems as compared to the Caucasians. And intra-arterial could be one of the reasons why in some of the middle income countries, Brazil, Iran and Senegal, they're using more intra-arterial as compared to IV TPA. The other reason for using more intra-arterial is probably the cost also. So now, going into the barriers to the stroke care in Pakistan, so we should divide them into pre-hospital, financial constraints and lack of infrastructure, because these all three directly or indirectly are related to the stroke issues. So what are the pre-hospital ones? The non-recognition stroke, that's the biggest one. We all see patients who are coming in from the villages a day or two after, or maybe a week or a month after, because they decided not to seek any treatment. We have cultural and religious barriers, a lot of religious barriers here, because like I said, even a surgeon wanted to take a spiritual therapy for a known carcinoma which was symptomatic. I don't want to go into the because यहाँ पे वो ऐसे को मसाना और खड़ा हो जाए religion की जो बात होती है, मगर ये है कि something is objectively seen has done a problem. So those are the type of things you're dealing with. जंगली कबूतर, ये मैंने बहुत चीज़ें यहाँ सीखी हैं. वहाँ पे सांप का तेल मल दें, फालिज हो गया, 1 महीने के बाद आ रहा है, पूरी डर्मेटोलॉजी के पास जा रहे हैं क्योंकि वो हुआ है. ये केसेस भी देखें. जंगली कबूतर खिला देंगे, वो गर्म होता है तो वो जल्दी ठीक हो जाएगा. बेल्स पॉलिसी में तो कबूतर बहुत यूज़ होते हैं, वो तो बहुत सर को भी पता होगा कि कितना ये मिथ चलता है इधर. Then we have variable health behavior admissions, late strokes, lack of national state ambulance service. So Punjab is the only state right now जिसने 1122 किया है. मगर if you are visiting KP or you are in Sindh, who are you going to call if you're in an emergency? If you're just visiting there, so we really need to have a national system of care, and then that can actually be integrated into the whole system. Even for acute coronary, trauma, GI problems, anything, we need a national ambulance service, not just one limited to one province.
So Qasim, in Punjab, when you call 1122, what is the mandated time that the ambulance comes?
7 to 9 minutes.
Is
Very good.
7 9 minutes?
Yes.
Anywhere in the province?
Yes, actually I've recently read it that when you call 1122, you're responding within 10 minutes. It's a research article.
In-
This is for city.
In the city.
In the city.
For Lahore, it may be as good as 2 minutes.
Like, how can you get into somebody's house in 2 minutes?
Yeah, but they are all the way.
So
They
just
are
all over the
Yeah,
city.
This service is of good international standard.
Because the reason I'm pushing you is that what is considered to be the world's best is in Berlin because we do collaborative research with them. वहाँ पे 16 minutes. 16 minutes is considered to be very, very,
Very, very good.
So
And
to-
for that reason, that's why they started doing it
Yeah.
in the ambulance.
Yeah.
The CPN.
Lahore is well.
आज कभी फोन करें यहाँ से कर दें फोन अभी कितने टाइम
पता चल
में?
जाएगा, अभी पता चल जाएगा।
अभी पता चल जाएगा
At least central part.
अच्छा।
They
Sir,
really
they
next
also
time is standard.
introduce motorcycle ambulances.
And motorcycle
So they're
patient.
reaching places where they can't
Motorcycle stroke patient
First
में
aid,
first aid treatment
first aid
is-
पहुंच जाता है।
So सब
जब
मानते
अकेला
हैं
पहुंच जाता है, खुद ही।
some अच्छा 7 to 9 minutes everyone agrees in the room huh?
Yes, definitely.
So once the program is over should we do how much do they charge you once they come over?
I don't think you charge anything.
6 feet.
अब फिर एक कर दें
करके देखते हैं।
क्या ख्याल है?
Bashir, the problem will start after the pick of the patient. Where the patient goes and how long does it get there to go
So
there.
any big government
If
hospital.
you are in Shadara, I was coming from Rawalpindi, Islamabad, Shadara to Lahore. Believe me not, there were 2 ambulances behind me and there was nowhere to go. There was
That's why
nowhere
we
to
were
go.
surprised how it can be in 2
And for
minutes.
40 minutes we were stuck there and they had no place to go.
But this is impressive. I mean, it's a good thing. I just want to make sure that you don't create your bar so high that it's not attainable. Even if they get there in half an hour, where
It's great,
nothing,
yeah.
where nothing exists, it's very commendable. Very, very nice.
So then, the pre-hospital, the stroke literacy, we need to recognize the vascular risk factors because this is where you can actually do the primary prevention, do secondary prevention. If you are dealing with these problems far more, so you can create less stroke patients. You need to recognize the symptoms, correctly identify the brain is where you have to go. I don't know of, I'm pretty sure in US, there are no cardiac ERs. It's one ER, if I'm correct, even in Canada.
Right.
Pakistan is the only exception where I've actually, and since I work at CMH, I frequently deal with this problem. सबसे पहले जिसको भी कुछ होता है, वो समझता है कि हार्ट का मसला है, स्ट्रोक हो रहा है, हार्ट का मसला है, जाएगा कार्डियक के ER में. वहाँ पे घंटा 2 घंटे लगा के तब वो कहेंगे कि न्यूरोलॉजिस्ट को बुलाओ. ये बहुत मेजर प्रॉब्लम है, क्योंकि you need to have just one ER, one emergency service, and those physicians need to be trained. And then that should be the bifurcating point. कहाँ से patient जाएगा, किसना जाएगा, क्योंकि that creates a lot of
triage process.
जी triage process. So that creates a lot of problem. लाहौर में PIC भी है, फैसलाबाद में भी है, हर जगह इस तरह के इंस्टीट्यूट कार्डियक के बनते जा रहे हैं, मगर I don't know whether that is the right way to doing the things. क्योंकि उन सब institutions में you don't have the other services who are needed there. क्योंकि उनकी complications होती हैं. उनके भी स्ट्रोक्स होते हैं, उनके भी हेमरेज होते हैं, उनके भी रीनल फेलियर्स होते हैं, कॉन्ट्रास्ट इंड्यूस्ड होती हैं चीज़ें, मगर उनके पास अप्रोप्रिएट स्टाफ होता ही नहीं है, और वो डायलिसिस वाले मरीज जो हैं वो भी और ख़राब होते हैं. सो दैट्स व्हाई आई थिंक द होल ओवरऑल स्ट्रक्चर needs to be a little bit reorganized as well. Then the behavior. Now in Punjab, I know people have started to use more of the 1122, but that is more easier way, and now there's a lot of campaign coming from the media, the government, politicians to make way for the ambulances. So the things are changing. People are getting educated, so more needs to be done. So obviously, when for both literacy and behavior, if you are improving on these two, you will improve the stroke proficiency. So some public initiatives and the seminars like these, stroke days, conferences, these do help. Telemedicine is a big one, because since we don't have the required number of neurologists in the country, so we can actually link via telemedicine to smaller centers in say rural Punjab, and have the appropriate services and triage mechanisms, and then improve on both the behavior literacy and the proficiency. So this is the poster that we actually sent out this year for the International Stroke Day, and Professor Athar was very kind and supportive in trying to help us design with all these things, and we decided that in order to sensitize the public, we should tell them that stroke is treatable. Because अभी जो common phrase आपको सुनने को मिलता है वो होता है कि अल्लाह ताला की रज़ा, जो हो गया वो हो गया, हम ब्लड प्रेशर करेंगे, डायबिटीज़ को करेंगे, और जहाँ विंडो में भी मरीज आते हैं उसके साथ उसको भी ये कह दिया जाता है. So that was our first objective this year. So we need to sensitize that it is treatable, there is a time window and there is a treatment available, and so that more and more awareness goes out. Now moving to the financial side, again we have to look at the gross national income per capita of our country, which is around 6,000. We fall in the mid-income country by the WHO category. TPA today is around $963. It's cheaper than in the West. I think it's around 1,400 or maybe more.
5,000.
5,000.
So it's cheaper, but for this part of the world, it's very expensive.
But this is the same dose, 0.9 or
0.9,
0.6?
2 vials,
Okay.
100 milligrams. So the number of doctors, 1 doctor to 957 people. यहाँ का survey है. By WHO recommendation, we need to have at least 5 per 1,000. So we are far behind in that. Even though I thought कि हमारे यहाँ doctors बहुत ज़्यादा हैं, मगर when I started making this presentation, going through the papers, I was kind of shocked कि we're not meeting the recommendations right now. हालांकि
Doctors are mal-distributed.
Mal-distributed. हाँ.
That's why you see more doctors in big cities, because there is no sir in rural areas. So district headquarter hospitals and other hospitals, primary health center, there even when there are doctors posted, there are empty rooms with no doctors there. That's why your proportion changes when you see the doctors that every second street has a doctor's clinic, but it's not true outside the city.
So of the total GDP, we last year I think 2017 it was 0.6%. अगर आप उसको करें और benchmark is 6%. अगर आप उसको 0.6 करें तो last year the government actually spent $3.5 per person per year. So आप just imagine अगर एक दवाई ही $963 की है, उसको सिर्फ stroke तो नहीं होना, उसको तो और कुछ भी चीज़ें में हो सकती हैं. The other big impediment right now, which hopefully will get settled soon in the next month or two, that's what we're being told by the distributor, is it's not registered. If it's not registered, it's not going to be available in any hospital, especially public hospitals. और अगर register हो भी जाए, then the question will come, who is going to convince and how the government is going to get convinced that they need to keep these injections in majority of the hospitals, क्योंकि there are budgetary constraints. जिसमें आप लोग आजकल भी देख रहे हैं, और क्योंकि हमारी community based surveys है ही नहीं, we don't know the exact prevalence and incidence, so we really have to, it will be difficult to convince कि कितने injections किस hospital में हो और क्या होना चाहिए. The other impediment is that we really need to start focusing on what is the impact of if you improve a patient by giving these type of treatments like acute coronary ulcer and everything, आप उसको एक अच्छी फॉर्म में वापस सोसाइटी में ले आते हैं, तो how does he or she contribute to the society well-being rather than being the burden on the society. अब हमारा भी वही टाइम है कि जिसमें majority of the couples, there are 2 working couples are working. पहले होता था कि एक ही हाउस होल्ड पर था, अब ये कि मल्टीपल जॉब्स, अगर एक बंदा काम कर रहा है तो आपको भी पता है कि 3 जॉब्स पूरे दिन में हो रही हैं just to meet the ends. So the reimbursement mechanism has to be figured out. अभी जो जितना thrombolysis हो रहा है, unfortunately it's all being done in the private sector, और वो भी बहुत थोड़ी स्केल पे है. I know कि अतर साहब कर रहे हैं, I'm doing it, but I don't know of any public sector hospital जहाँ पे TPA available होगा.
So what are you doing in your hospital? Is it your hospital?
No, I'm doing it in the private hospital setup.
So private hospital is insured?
हाँ?
कौन सा hospital?
मैं कर रहा हूँ हमीद लतीफ़ पे और उमर पे.
And how many patients? Sorry to interrupt. How many patients do you see?
So in the last 3 months, I think IVTP I'm giving like 1 to 3 a month.
1 to 3 a month.
अब शुरू हो गया इतना.
अच्छा सर, आपका हॉस्पिटल कौन सा?
मेरा नेशनल हॉस्पिटल डिफेंस.
वो भी प्राइवेट है?
वो भी प्राइवेट.
वहाँ पे कितना है?
वहाँ पे लास्ट 3 मंथ में 4 पेशेंट टाइम पे पहुँचे.
And you stock it in the hospital?
जी. So वो मैं आगे करूँगा क्योंकि obviously no, even in the private hospital no one is willing to pay for the drugs upfront. तो so that becomes an issue कि किस तरह करें, फिर वो इसकी डेट ऑफ एक्सपायरेशन है, ना यूज़ होगा तो मसला हो जाएगा. So we need to develop stroke centers in the public sector, limited number of CTs and MR scanners, which I talked about before. We talk about the primary and the secondary prevention, but we don't even think of the rehab, which is a very important component in stroke recovery. अब ये भी जो चीज़ें हैं ये इवॉल्व कर रही हैं ऐसा ऐसा, मगर ये कि उस स्पीड पे नहीं है जितना कि हम चाहते होंगे. वी हैव अ हार्ड टाइम फाइंडिंग स्पीच एंड ऑक्यूपेशनल थेरेपी लाहौर में शायद एक या दो हैं, मे बी शायद वो सेल्फ ट्रेंड ही होंगे, हाँ, और कोई नहीं होगा. मगर ऑक्यूपेशनल थेरेपी इज़ वेरी इंपॉर्टेंट. अगर किसी यंग को हो जाता है, यू नीड टू help them how to get back into the society and to get back to work. We don't have any social workers to deal with their problems afterwards. So जो most recent अभी हुआ है ये चीज़ हुई है, turf wars शुरू हुई, जिसका setback हुआ है हमारी को भी, क्योंकि and before I go into this thing, I'll talk about a psychiatry component, a Dunning-Kruger effect. Does anyone know कि Dunning-Kruger effect क्या है? So this is a principle that was explained in 1999 by these two authors, Dunning and Kruger. And basically what is there's a cognitive bias that leads people to overestimate their abilities. Lack of insight and illusion superiority can affect judgment. Skills in one area may include a sense of invulnerability in another, and the effect may persist despite appropriate feedback. मतलब ये कि मैं neurologist हूँ, मगर मैं cardiology practice करने लग जाऊँ, या GI करने लग जाऊँ, या dermatology करने लग जाऊँ, या vice versa, ठीक है. So, am I the right person to deal with that patient? I don't think so. मैं अपनी फील्ड में जितना एक्सेल कर सकता हूँ, मगर if I start cross over तो फिर एक प्रॉब्लम है. वेस्टर्न कंट्रीज में तो गाइडलाइंस हैं, वहाँ तो ये चीज़ें नहीं हो सकती. पाकिस्तान में यू आर डीलिंग विद स्पिरिचुअल लीडर, यू आर डीलिंग विद हकीम, यू आर डीलिंग विद एवरी सॉर्ट ऑफ फिजिशियन जो कि हर चीज़ कर रहा है. तो यहाँ पे ये बड़ा प्रॉब्लम है, क्योंकि ये आपको डायरेक्टली और इनडायरेक्टली स्ट्रोक के मरीज को ही ख़राब करेगी. इसको अगर आप ग्राफ फॉर्म में करें तो दिस इज़ हाउ इट लुक्स लाइक कि आप एक स्पेशलिटी में ट्रेन होते हैं, मगर देन यू से ओके आई कैन डू द अदर ऑल्सो, क्योंकि आई कैन गाइड द कैथेटर. अब नाउ वी गो अबव द हार्ट, सो वी कम फ्रॉम द फेमोरल आर्टरी, मेक आवर वे, वी गो अबव द हार्ट, बट समटाइम्स वी डू गो इनसाइड द हार्ट, क्योंकि वायर उधर चली आती है, मगर देन वी मेक आवर वे आउट एंड वी गो अप. सो वी रियलाइज वी आर इन द अनचार्टेड टेरिटरी, मगर वी देन सेलेक्ट. मगर ये कि अब इफ़ आई से कि मैं गाइड कैथेटर ब्रेन में लेकर जा सकता हूँ, तो मैं हार्ट में भी ले जाऊँगा, मैं किडनी में भी ले जाऊँगा, मैं लिवर में भी कर लूँगा, मगर मुझे लिटरेचर का तो पता ही नहीं है, और ना ही मुझे उसकी चीज़ों का पता है कि कॉम्प्लिकेशंस क्या हैं, उसका हाउ टू मैनेज दोस थिंग्स. एंड दिस इज़ हाउ इट लुक्स लाइक ऑन अ ग्राफ फॉर्म. सो नाउ मुझे जो दो चीज़ें अच्छी लगी थी व्हेन आई वाज प्रिपेयरिंग फॉर दिस टॉक वाज के देयर आर टू मॉडल्स. One is the Russian, and the other one I'll talk about the next one, Spanish. The Russian model actually started getting implemented in 2008. They recognized the stroke therapies, the value of stroke interventions early on. So they decided to come up with one comprehensive center for every 1.2 to 2 million population. Itni population में बस एक center ही होगा. And then they started linking them with telemedicine to a network of 3 to 6 primary stroke centers. And then in 2013 ये project खत्म हुआ, and they've actually improved their IV thrombolysis, they've improved the thrombectomy numbers and everything because how they started off. If you look at the Brazilian experience, उन्होंने भी यही चीज़ को किया मगर different form में. They actually had 4 levels. Level A was a comprehensive, B was hospital with neurologist and CT scan 24/7, but they didn't have MRI or endovascular. Level C was a remote center जहाँ पे thrombolysis with telemedicine हो सकता था, मगर was connected to level A, and level D was the least of the centers जहाँ पे कुछ भी नहीं था. So what I think is कि if we can improve on our pre-hospital assessment and EMS transport mechanism, public and everything, that pre-hospital जितनी भी हमारी चीज़ें हैं उसको हम साथ साथ डील करें, और we definitely need this. You cannot do without government support. And then have provincial comprehensive stroke centers. आप पंजाब में लाहौर में आपके 3 आसानी से बन सकते हैं. फॉर इंस्टेंस एक सेंटर में के एक एंड पे एलजेस दूसरी साइड पे, और सेंटर में एक आपका जहाँ पे अदनान है फातिमा जना, मतलब कि you can cater to this thing and then you can link these comprehensive centers to the smaller ones. TPA in the beginning can be brought into these centers. अगर आप channel और public education तो करेंगे कि इन्हीं पे stroke मरीज जाएंगे, तो you can easily cater to all these things because they have all the infrastructure is right there. You just have to put the dots together. Stroke units वहाँ बने, thrombolysis हो, complications, everything is there. And then these should be the ones who should be driving the data. कि stroke की incidence क्या है, prevalence क्या है, complications क्या है, कितने TPAs हैं. So we start maintaining our data banks from here. Infrastructure, we need to have these post-stroke protocols for prompt delivery in all these centers. There was a paper that was published from AKU in 2013, which was very interesting because they found in their ER, after looking at around 40,000 patients approximately, that 32% of the patients waited for more than 180 minutes before leaving without being seen. और इसमें काफ़ी stroke patients थे. So this is extremely disappointing. अगर AKU में ये चीज़ हो रही है तो public sector में तो इससे भी ज़्यादा हो रहा होगा क्योंकि वो तो बहुत overburdened है. So the golden hour we have talked about, we need to shorten these things or we need to improvise these things according to what our things are. Maybe our transport is better, but maybe our in-house things are not better. So we need to maybe bypass the ER and go straight to somewhere like CT scan, just like Dr. Shuaib was pointing out. So maybe that is better because अगर neurologist को guide कर रहा है, वहीं echo check हो जाता है, blood pressure हो जाता है, and you have a basic history that there is no liver or renal problem, then who cares? You just give TPA based on the CT scan. You just bypass everything. But like I said, you need to figure out all these things based on what is happening here. We need to improve the mean to low needle time. यहाँ पे hemorrhages बहुत ज़्यादा हैं. This is again coming from Karachi. One experience where they actually used a TPA and they found that the mean time was very high. Obviously, the patient selection and then the learning curve was there. They had high hemorrhage rate क्योंकि normally 6% ज़्यादा नहीं होना चाहिए. So the other thing is that since 1996 of the TPA we've been talking about that time is brain. 3 hours, 4.5 hours जो है वो time is brain. There was a recent paper from Australia. I forgot to find the reference for it. But that was very interesting because they actually triaged the IV TPA patients based on CT perfusion and improved the TPA recanalization to 60%. Because every stroke patient was getting CT perfusion and they actually triaged who's going to get TPA, who's not going to get TPA. But again, for this part of the world, maybe it's not possible because TPA, CT angio, CTPs are going to be expensive. And obviously, these have to be linked with community stroke, general neurology for maternal secondary prevention, and these patients should be sent back to their area of community. और वहाँ पे ये सारी इनकी further चीजें हों, community support or rehab and everything. These are some important points because I've learned when I came back in 2012, there was not a single company that could provide me neurodisposables, not a single company. The option was that I invest my own money, मगर वो है कि जो companies हैं वो आपको ये इस तरह के disposables या drugs नहीं देती हैं जो physicians को. There are certain international laws which forbid them. They can only sell these things to the hospitals or to the countries. So I developed a consignment system by companies, industry को कहेंगे ठीक है, we will give you the volume, we'll work with the public education and everything, and they should start putting them on consignment basis. अब TPA भी जो हमने रखवाया वो consignment पे है. None of the private hospitals are actually paying for it. So we pay them once a TPA is used. We do thrombectomies or anything of that sort. We have them on consignment क्योंकि वो एक extra step को hospital को convince करने का bypass हो जाता है. In my opinion, I think कि बजाय government को कहा जाए कि आप हर hospital में इतना TPA रखें क्योंकि एक lump sum chunk बनेगी. क्योंकि TPA एक ऐसी चीज़ नहीं है कि जहाँ पे हर कोई लेफ्ट एंड राइट यूज़ करेगा. उसका बहुत स्ट्रिक्ट इंक्लूजन एक्सक्लूजन क्राइटेरिया है. If we are able to develop the centers, we just convince the government कि आप जो मरीज TPA जहाँ से उसको लगता है उसको reimburse कर दें, उस इंस्टीट्यूट को कर दें या उस कंपनी को कर दें जो या डिस्ट्रीब्यूटर को. एंड इट कैन बी डन क्योंकि ये चीज़ें ऑलरेडी हो रही हैं और भी चीज़ों में गवर्नमेंट करती है. जहाँ पे जो चीज़ें रेट टाइप हो रही हो तो वहाँ पे गवर्नमेंट रीइंबर्स भी करती है डॉक्टर. ड्रैप जो है ड्रग रेगुलेटरी अथॉरिटी पार्ट का TPA मेरे ख्याल में इस वक्त सर को पता होगा शायद अब 2 साल से लगे हुए हैं रजिस्ट्रेशन के लिए. 2-3 years हो गए और अभी भी वो कह रहे हैं कि 4 महीने और लगेंगे रजिस्ट्रेशन को. और तो you can just imagine कि 1996 में ड्रग अप्रूव हुई भी और अभी तक हमारे यहाँ रजिस्टर्ड नहीं हो रही, उसको 3 साल तो ऑलमोस्ट होने को हो गए. So it needs to be revamped. We need to actually have a lot of neurology positions created in academic and large public hospitals because this is the main force which will actually drive the whole thing. Otherwise ये चीज़ नहीं हो सकेगी unless more and more neurologists come into the field. The other thing is that we need to, just like in the developed countries, we need to have strong liaison with neurosurgery and neuroradiology. We need to have consensus guidelines pertaining to neurosciences. Obviously, people like Dr. Ismail, Danish, Dr. Shuaib, and all those people who are taking an extra effort, extra time, coming from their own resources to help us in this part of the world. We need a lot of their support and guidance how to get the things moving because they can share their experience and help us in our problems. We need to have advocacy groups just like American Academy of Neurology जिनका एक पूरा separate group है which just उसका task ही सिर्फ ये है to go to the parliamentarians and convince them कि why this thing is important, epilepsy, stroke, इन सब चीज़ों को. And then a lot of stroke survival campaign जो outcomes हैं वो highlight हों, media important करे. The problem with the media in Pakistan now is that there are so many channels. Magar, if you want to even do an education highlight, वो आपसे पैसे मांगेंगे. मेरा तो अब ये experience है कि वो भी आप आने के भी पैसे मांगेंगे to run a campaign. तो which is unfortunate कि ये चीज़ें तो बहुत चीज़ें हैं जो थोड़ी सी sideline हो रही हैं. And lastly, again वही जो चीज़ मैं आपको पहले बता रहा था इस slide में कि 20 to 24 people एक पिट में होते हैं. एंड हमारे शायद से कम ज़रूरत है ER में और एंडोवास्कुलर को मिला के अभी करें तो शायद इतने ना हो. अगर एक पिट पे ये इतना कोऑर्डिनेट कर सकते हैं और विद वन पर्सन स्टैंडिंग राइट हियर द लॉलीपॉप मैन, तो वी रियली नीड टू लर्न हाउ दे कैन डू इट, हाउ दे आर एबल टू कम्युनिकेट एवरी पर्सन जिसका एक अपना स्पेसिफिक टास्क है. दैट्स अमेजिंग कि हाउ दे कैन चेंज 4 टायर्स इन 4 seconds. थैंक यू जी.